All right, so good morning, everyone. Um, Thank you, Christy, for your kind introduction. Um, how many people do we have on the call today?
We have about 88, but we did take a break, so I think people are also coming back.
Okay, fantastic. So I'll try to be short and concise in order to leave some time for questions. And look, this is a new subspecialty that I can talk about much more than an hour, but I'll try to deliver the main messages to people that have not heard about neuroplastic surgery yet and leave some room for questions. So thank you for accommodating this talk. Um, of note, all the patients and stories that you'll see on my slides are with patients' permission. I just please ask you not to screenshot any of those slides where patients are actually being presented for their own privacy. So I'd like to start. I'm going to jump some slides here as I really want to leave some room for questions. And I'm going to start and share this image. All of those are my patients. And I would like to ask you which one of those patients you think or you guess had a large brain tumor that protruded through their forehead and was the size of an orange? And try to take a minute to guess. And then the next question that I ask you, if you had to guess which one of the patients lost their skull for trauma, where half of their skull was missing and was then reconstructed with customized 3D printed implants, try to look around and guess which one would that be.
For your first question, a lot of people are saying top right, and then for your second question, a lot of people are I see top left, second left, bottom right.
Okay, those are great answers. So essentially, all of those patients had been going through major brain surgery and lost their skulls for a variety of reasons. And all of those patients are now reconstructed with essentially customized 3D printed implants. And we're going to show some of those stories and share how we do it. But this is just to show you that neuroplastic surgery is a new field that is bridging the gap between neurosurgery and plastic surgery. And we're aiming to deal with complex cranial reconstruction and to ensure patients have complete preservation or restoration of their preoperative appearance. Now, why is this important? If you look at the literature, and this is one of the patients, his name is Tucker. He lost his skull for a trauma. We'll see his story. And when you look at the literature, after patients losing their skull and they need to come back for reconstruction, the complications rates are extremely high. In fact, 35 to 40% complication rates when the patients come back for reconstruction. And we, for quite some time as neurosurgeons, struggle to understand why the complications rate are so high, mainly infection and exclusion, device explantation, and need for another operation. And this is where this field was born to try to dedicate the research efforts to understand the timing, techniques, and the materials for those type of surgeries. And the data shows that this is a large meta-analysis from Stanford, shows that out of 8,000 patients that underwent cranioplasty with 8-year surveillance, third of them are failed. Now, 1 out of every 3 patients failing is a big number, and failure is mainly for infections, hardware exposure, need for reoperation, bleeding, and seizures. So we understand there is a need here for a new subspecialty to train surgeons to dedicate their expertise to adult reconstruction. Now, why is there such a gap in knowledge? The idea is neurosurgeons are focused on the brain and spine, and I'm sure you heard a lot of beautiful and amazing talks about that. And plastic surgery are mainly focused on the entire holistic approach to the body, but there is no dedicated subspecialty to focus on those specific patients that are post neurosurgical procedure and now need reconstruction. So this is what we call the no man's land. That is mainly was undesirable by both fields, and I'll explain why. The one example that I like to give, if a woman get diagnosed with a breast cancer, as you see on the left side, she'll be seeing the breast cancer surgeon and the plastic surgeon before surgery. Then they will take her to a multidisciplinary planning group to offer both resection and reconstruction of the breast. A brain tumor patient will see the neurosurgeon, will take them to surgery, but what happens if they have problems later, like deformity, temporal hollowing, scalp dehiscence, device exposure? We are not the experts to deal with those complications. Neither are general plastic surgeons, and this is the question mark that we're here to answer. This is just few example of cases that we see on a daily basis. This is, for example, a patient that had a mesh cranioplasty before, and now you see the mesh poking out of the skin. This is a patient that had a scalp tumor, now come back with recurrence and infection. This is a patient that had scalp necrosis. This is a severe craniofacial trauma. This is severe metastasized tumor to the scalp. And those are cases that, for the most part, neurosurgeons don't really like or know how to deal with. And plastic surgeons are don't have a big desire to do them themselves. And I'll just go over some cases and some literature to show you why it's such an important paradigm shift to have a center of excellence. And this is a case that I had to review. Basically, another institution had this case for us to opine on, and this is the first CAT scan showing a large brain bleed on the left side of the brain. Patient underwent decompressive hemicraniectomy to remove half side of the skull to allow the brain to expand, to basically swell. Once the patients recover and the brain swelling resolve, patient is undergoing cranioplasty. You see this smashed implant on the left side. And then it got infected. And as you can see, there is exposure of the flap here. And after 17 operations, eventually, the patient turned out to be reconstructed this way. And this is basically after multiple surgeries, multiple incisions, multiple attempts. And this is still in 2023. So we're here to basically deal with those complex cases in order to give a better and more profound, generalized and complete approach to those patients. This is example of a patient with a likely extraaxial meningioma that involve both the brain, the dura, but also the skull and the scalp. Same here, involving the frontal sinus, which adds another component in the operation planning, resection, and reconstruction. And I'll show you some of those cases in details. Well, for example, this patient that underwent multiple surgeries before for this high-grade 3 meningioma of the skull base face, underwent multiple resections and reconstructive attempts, and now this tumor is coming back. So the challenge here is, after removal of tumor, is to close things up and reconstruct the patient in a way that she'll go back to society, thrive, and would not suffer complications associated with inadequate reconstruction. So I'm proud to share that back in 2021, we wrote the first book chapter in the Schmiedican Suite, which is basically The Bible of every neurosurgery resident starting residency can now learn, understand, and implement those algorithms into their practice, how to basically deal with complex scalp and skull. And when we look at the data, we found that if you look at 500 cases, we identified those 500 cases that came from reconstruction, and we called it primary versus revision type. And we identified that if you are a patient that already had a previous reconstruction attempt and you're not going to a center of excellence that is dedicated for those type of procedure, the complication rates are threefold higher. And the main complications type are dehiscence, surgical site infections, epidural hematoma, temporal hollowing defect, etc., etc. That's why we understand that we need a center of excellence that is mandatory to give a very specialized treatment. This is an example of such a patient that had a trauma many years ago and lived a meaningful, independent life. And then he goes to the surgeon with a little draining fistula, as you see on the left side of the temple. He goes to another institution that is not dedicated to those type of patients, and they try to fix him. After 7 surgeries where they failed, he now looks like this. And this is what we try to educate patients, surgeons, physicians. If a patient comes in like this, send them to a center of excellence with neuroplastic surgeons before this turns out to be a disaster like this. So from a high level view, neuroplastic surgery bridged the gap between plastic surgery and neurosurgery. And we're dealing with oncology, vascular, CSF disorder, functional, neurotrauma, neurotechnology based on scalp reconstruction, tissue transfer, complex wounds, and I'll share examples from each and every one of those subspecialty. Based on our data and research that was done at Hopkins, where I trained in this, we found that when you look at those patients and you bring other experts to identify the gaps and to look at each and every patient as individual with multiple different subspecialties, we can reduce the complication rates from 36 to 15%, which is a major advantage for patients that otherwise would have suffered so many terrible side effects of surgery. And those results suggest that it is critical to optimize the outcomes at the first cranioplasty. So if somebody comes in with need of reconstruction, it's better for them to go into a center of excellence where there is a collaborative approach to improve their outcomes. So this is Tucker. He had the trauma. As I said, he lost the left side of his skull. We are sending the CT to our engineers to essentially build and create 3D printed implants that can be as simple as implant to cover the bone, as advanced to also compensate for soft tissue loss, give us heat maps in case of cancer, and also accommodate technology, which is what I think is going to be the future of this. And we take them to surgery. As you see, this is the left side scar. We open the scar, we elevate the flap into the spericranial only technique. We put the implant that fits like a puzzle piece. As you see, it's clear. Attach it with plates and screws. And voila.
Well, a patient who was left with a deformed skull after a life-saving procedure is back to living a normal life thanks to a medical team at Lenox Hospital. Leading the team, the world's first neuroplastic surgeon. Eyewitnesses reporter Sonia Rincon with more from the Upper East Side.
This is what Tucker Marr of Manhattan looked like only a few months ago. He loves playing hockey, but it was a tumble down a flight of stairs that landed him in emergency brain surgery.
I had a fractured right skull and a left-sided subdural hematoma, so brain bleed.
The surgery saved his life by removing part of his skull, since pressure on brain swelling can be fatal.
So for a while, that looked very normal, right? My brain was swelling, so it replaced that area.
Then the swelling came down. He wore a helmet to both protect and conceal.
It taught me a lot about how we as society and humans deal with deficiencies in other people.
When he came to us, he had a severe deformity and a dent in the side of his head.
But putting back the old piece of skull bone carries a risk of infection. Dr. Nadi Ben Shalom at Lenox Hill Hospital is the first neurosurgeon to develop a specialty in neuroplastics, minimizing risk by 3D printing implants made of acrylics and performing a second surgery.
There are a lot of patients survived brain surgery, but they don't look like themselves again. That they don't feel like themselves again.
This is what Tucker's implant looks like. It's reinforced with plates and screws. Dr. Ben Shalom added extra ones, he says, because he wants Tucker to play hockey again.
The brain functions better when it's protected.
It may seem like a no-brainer, but Dr. Ben Shalom's work, marrying neuro and plastic surgery, is catching on.
Everybody can do everything else the old-fashioned way, but I think, and I really believe this is a very novel subspecialty that's going to take off, and we'd like him to lead it.
Tucker Marr's scars are healing, and he's training to run the New York City Marathon, just as he was before he fell. With a reinforced skull and sense of optimism, he says he hopes to motivate others who may find themselves with challenging recoveries.
It does come. It doesn't matter how long it takes. It does take that mindset, and you have to keep moving.
So thanks for Tucker to sharing this amazing story. He basically ran the marathon just 6 months after surgery and this great score. And his case was featured in the New York Times. The reason it was featured in the New York Times is because the implant we use is made of very special material called acrylic clear polymethyl methacrylate, which allows us to look at the brain with an ultrasound, something we cannot do before. So basically, we generate a window to the brain, and with a standard clinic ultrasound, we can look at the patient's brain and identify structural anatomy and pathology, which I was very excited that the New York Times came and do the article about that. This is just another case showing how we use the ultrasound in bedside after the large implant is implanted. The anatomy that we can identify and we're investigating is quite remarkable, as the more you do it, the more you can actually look at the different structural anatomy and understand in details better and save what we show. We can save many CAT scans to those patients. The technology was published in multiple pathologies, such as hydrocephalus. This was published last year in Neurosurgery Journal. As you can see, patients come in for a VP shunt. The bronchial is covered with a small clear implant, and the CT is comparable to the ultrasound to identify the size of the ventricles in order to adjust the shunt settings at bedside without needing or essentially preventing and avoiding unnecessary CAT scans. This is another patient that you saw. He had a severe trauma to his head. He was a car accident. He miraculously survived this accident, and but essentially after reconstruction, he was left with a bitemporal deformity. As you can appreciate, his head is very asymmetric. He's 19. Every time he looks in the mirror, he's, it reminds him of the trauma and immediately takes him to the basically the accident. And he comes to me after he'd been seeing other surgeons that try to fill that with injections or whatnot, but all those are temporary and not really working well. We did this very advanced 3D printer modeling and monitoring to provide the bilateral reconstruction of the temporal defect with very sophisticated techniques, so we don't injure any nerves, given the multiple previous surgeries and the risk for scar tissue. We 3D printed those implants and we fit like a puzzle piece. And this is him just 3 weeks after surgery coming to remove the stitches. And this case was featured in the New York Post. And you can imagine a 19-year-old boy, you want to go out, have fun with his friends, go to work or school, doesn't want to have any stigma about his looks. And I will, encourage you to look at these patients and ask yourself which one look to you happier and more fulfilled, as I feel that the self-confidence and well-being is as important to the overall survival and prognosis as the disease itself. This is another patient that came in with a device exposure. We talk a little bit about VP shunt. We can now replace the skull with a small implant, embed the VP shunt inside the skull, and reduce the volume and the basically the high profile shunt from the patient's skull. As continue talking about advanced implants, this patient, as I showed you before, we designed a skull-based implant that will reconstruct the orbital roof, but will also provide slots for intraoperative radiation seeds, which are those small beads embedded with cesium-131, which is essentially a local radiation field that we implanted in time of surgery in order to have long-term local disease control. Given the fact that this patient was already radiated, we can now modulate and change the implant design in order to fit in the radiation seeds in the implant and to provide long-term local control. And in summary, you'll see those three cases, basically how we can implant computers and technology within those implants. This is the VP shunt, this is the wireless ICP monitor, and this is the epilepsy computer. As I showed before, another field that neuroplastic surgeons are involved is implantable neurotechnology, and this is a case that I did with Dr. Ashmeda and Chad Bowden at the Feinstein Institute, essentially restoring upper arm functions for a patient with a C5 injury, and we implanted those 5 chips in the brain while he's training himself, connecting to those brain-computer interface. After less than a year, he was able to regain sensation and elevate his both arms. I encourage you to look at this story. This is very inspirational. Our research is very robust, both in the field of cranioplasty as well as brain tumors, as we try to identify opportunities to implant those small clear implants in order to essentially follow up on tumor growth in the clinic as a patient come in for the normal post-op checks. So we can put an ultrasound on the brain through the window and identify if there is any early recurrence. This leads us to write the second book chapter about brain-computer interfacing and prospect of technical aspect of functional cranial implants. So in summary, the first half of our talk is just showing you the evolution of neuroplastic surgery, the need and the solution, as well as where we're heading. So this is the second part, but I'll show you some cases. This is the patient that you saw on the first slide. He came in with this large mass that is protruding through his forehead. MRI demonstrated this large extra-axial lesion involving both the dura, the skull, and the scalp. We take him to, thanks to our amazing group with designated physicians, we take him to the IR suite for preoperative embolization. You see the contrast material here through the MMA and STA and the blush providing the tumor. And we embolize it to basically reduce the amount of bleeding and the live vessels pre-operation. Then we send all the information to our engineers to essentially build 3D model to segment our approach, our incision, our osteotomies, and then we print the patient-specific skull and anatomy, which is essentially based on one-to-one the MRI and CAT scans. So I can have the anatomy and the patient-specific pathology in the office, learning, understanding, and targeting and rehearsing the surgery itself. We take into the operation, we do this large incision, we decapitate the tumor, we use our cutting guides, we remove the tumor, reconstruct the dura, and then we put the implant that fits like a puzzle piece. As you see here, we close the skin to make him look like himself again in 3 weeks. This is just not just a reconstructive aspect, but you have to understand that this patient will need cancer treatments, both chemo and radiation, and this approach allows us to give him much more safe and durable reconstruction for his journey, as we know that radiation and chemo can really influence healing and can basically can contribute to multiple complications. So working around the brain and working above the brain is as important to the recovery and the overall prognosis as anything else. And we published those techniques, how we specifically design the implants to perfectly fit the expected defect based on our preoperative 3D modeling. This is another patient that lost her forehead for cancer. They come in for the reconstruction. We print the patient's own skull model. And then preoperatively, we essentially bent and curve and cut the mesh, sterilize it, and put it in position so patients can essentially look like himself again just 3 weeks after stitches removal. And this is him, as you saw in the first picture, just a year later. This is another patient that came in with a large skull-base tumor involving both the brain, the skull base, and the face. She underwent multiple operations and treatments in other places, and she went and seeks for help in multiple other institutions in New York. However, all of them told her there is nothing to do and accept palliative care, which is essentially giving her a lot of pain meds to control the severe pain that she had. She was already on high dose opioids. This is very terrible situation when surgeons and doctors tell you there is nothing else to do. She luckily found us, and we assembled a team of big group of world leaders, both brain cancer, skull-base cancer, skull-base reconstruction, head and neck, facial plastics, ENTs, to essentially give her hope and a chance. And we did this very advanced operation where we use all the techniques and technologies to essentially build the patient's specific model. We took her to the OR for this big case with intraoperative radiation seeds. I have to give the credit to my collaborators, my partners, the oncologist, the radiation oncologist, and the other surgeons. Together a big, long 20 hours operation where the entire tumor was removed. This is her just a week after surgery, does not need any pain medications anymore. This is her removing the stitches and basically giving her life back. So neuroplastic surgery in 2025, there is a fellowship, there is a society. We built a program at Lenox Hill. We're pretty much regained a lot of popularity in mainstream media, given the specific care that we are giving to those patients. We teach that in the CNS. We're doing a course once a year at Northwell for the residents. We have a research fellow, Dr. Ferreira, which is going to talk to you on Monday. We assembled an ultrasound course. We started basically a case conference. And this is just to show you that all you need is a desire to change something in order to develop a big field. I have to give the credit to my mentor and founding father of this field. His name is Dr. Chet Gordon at Hopkins. He's the really revolutionary that came up with this field and worked very hard to build something from scratch. And I really honor him and dedicate this talk to his amazing qualities as a human being and as a surgeon and visionary. Right on time. I'll leave some time for questions and give you some time back to your life. Thank you.
Yeah, thank you. Brain turns, if y'all want to go ahead and just put your questions in the chat or in the Q&A, and I'm going to give y'all some time for that. We did have one question come in asking what made you choose this specialty. Maybe you can kind of talk about the beginnings of neuroplastics and what made you decide you wanted to do that.
Yes, absolutely. So I saw the need early on in my training as a neurosurgeon that we are not really experts on those type of things. And I saw a lot of young patients coming in deformed and feeling like not themselves. And I asked my teachers, how come we don't know how to fix it and nobody else can help them? And this is where I started to realize there was a huge need here and a desire to help those patients. And this is how I found a group at Hopkins and went to do my research there. So absolutely, it came from the internal desire to do better and help those patients that otherwise lost hope. And every time they looked in the mirror, they felt, depressed. This is what made this. The way that it started is back in 2016, as I mentioned, Chad Gordon was working at Hopkins closely with the neurosurgery department, and he envisioned there are so many problems that the neurosurgeons just don't have the expertise to fix, and it's not their um, fault. We're not trained in this as neurosurgeon. Our training is focused on the brain, and then he said, well, let's build something together, and it just with a lot of hard work and grit and perseverance, it established itself as a new subspecialty within neurosurgery that I'm very proud to be the first neurosurgeon to train in.
Yeah. With that, somebody out of curiosity was asking how many years did it take for you to get here? And then they also asked where do you see improvement or room for improvement in the specialty, and if you plan on implementing AI into the specialty at some point.
Um, I don't really understand the first question of how many years it took to get
I
here,
think they
but
were
I can.
asking about like if it was like a fellowship or if it was another residency. I think that's kind of what they're.
Oh, I see. Yes, so it's more fellowships. After your training, you need to do more fellowships. I did almost 2 years, 1 year of research, 1 year of clinical fellowship at Hopkins, and came for another fellowship in brain tumors at Lenox Hill. In terms of the evolution of this, I think that the future is going to be a lot of implantables. The field of BCI and implantable neurotechnology is getting a lot of popularity beyond academia, and I think that we'll be the experts to essentially um, design those technologies to go into the skull space.
Yeah. Somebody had asked for the woman that had the facial tumor, if you knew why it was deemed inoperable by other doctors, and if you can talk a little bit more about what was unique about your approach.
Yes, so that's a great question. What I will say is, once a patient was already operated once at chemo and radiation, the entire field is scarred down and much more difficult to go back into. And the problem in those operations is not necessarily the resection, because let's say you can remove the tumor, but what do you add to patients' quality of life, right? Do you add time? Do you add value? Do you add meaningful, pain-free? And if you do, how can you ensure that once you remove the tumor and you saw how big it is, you provide quality? Because if you remove the tumor and she ended up with multiple other deficiencies and leaks and infections, you didn't do any service to those patients. And because we assembled a world's renowned team of leaders, we could identify how we can remove the tumor, add radiation locally for local disease control, and perform reconstruction in a way that is going to be durable and send her back to her life. This is thankful to multiple world experts that worked together and formulated this plan. And I think that the reason she was deemed inoperable because other surgeons did not want to take the risk or have the expertise to work together to allow those patients a guaranteed positive outcome, which is sometimes scary. Those are rare cases. Those are not cases that we do on a daily basis.
Yeah, definitely takes a team and knowing. Um,
Mm.
Somebody else asked, do any of the implants, or I guess, do any of the patients reject the implants? What do you do if it rejects or causes infection?
Yeah, that's a good question. So normally implants do not reject. Normally implant either get infected and then you just have to remove them, treat with antibiotics, and then do another surgery to put it back. Those are terrible outcomes and terrible complications that we hate to have. Um, So infections, meaning removal, meaning 6 weeks of antibiotics, and then reimplantation.
And then somebody also asked what you thought about if this field would be feasible in LMICs
In what?
in low and middle income countries.
Oh, absolutely. I think that the need for this type of field in low income countries is even higher, and we're working with different associations to provide care, education, and expertise to multiple other regions of the world. This is my mission statement to be able to share and provide education, research, and clinical care. So I've been giving talks in India. I've been giving talks in Nigeria. I've been giving talks in Brazil, Europe, and hopefully we'll be able to go and give those services to others so they can help too.
I guess kind of along the lines of that, somebody was asking if for you, if language was ever a challenge during medical school or fellowship.
No.
And then somebody else asked, what is unique about the acrylic material used for the implants that makes it visible through ultrasound compared to other alternatives?
Yeah, so basically it's pressurized in a way that you saw it's clear to the visible naked eyes. And the research showed that it's also clear or sonolucent to ultrasound. The material itself can basically does not reflect back, any sound waves or any light waves. And that was a big revelation once we able to show that ultrasound waves penetrate. The reason that it's clear, it's because of a special process to pressurize the material in a way that all the micro air bubbles are being pushed outside of the field in the manufacturing process.
Yeah. Somebody had also asked with the implants if that is solely the only implant that you use, or when you know that you want to use that, or versus not using it.
Yeah, there are a few implants out there, few different materials. I use all of them based on location, size, history, pathology. It's basically there is no one size fits all, and luckily we have few options. So yeah, I would use them based on you know patient specific situation. It's a case to case basis.
Yeah. Somebody else asked, what is your approach, or what you feel is most important when seeing these patients, and deciding how you're going to approach the patient surgically?
Yeah, it's a good question. So I try to personally get to know the patients, right? What are their wishes? What are their goals? What do they do in life? Where do they want to get in life? In order for me to provide this more, I would say, complete and holistic approach, I try to view patients as human being and as a whole, not only as a disease, as we sometimes forget that the patient is more than just the MRI and the pathology. So I really try to get the patients to connect, to understand what do they want to achieve in life. And that helps me to get their personality better, to get to know how to tailor my treatment to them as human beings and not only as a pathology and a disease. And this is my approach on how do I essentially connect with my patients as well.
Yeah, definitely. Somebody else asked, can you talk more about the modeling process? How long does it take to model the patient's anatomy and create a customized implant?
Yeah, so I would say it takes around 2 weeks from the time we send the images to DICOMs to the engineers till the implants that they are ready to be used. And this process, including uploading the DICOMs to the 3D software, doing a conversation with the engineer where they mock and model and mirror the defect and give you their opinion. Then you go on a call and ask them for modification. Once you approve that, they send it to manufacturing and production sterilization. It's a 2 weeks process.
Perfect. Somebody else asked, what was your most memorable case?
Memorable. Every case is memorable. I remember all my patients. Every case has a unique perspective. No case is like any other. And this is why this field is so much, fun, and I love it and enjoy it. I can come in the morning and treat, young person with severe skull deformity after, trauma or stroke. And then right after I can jump into awake craniotomy for a brain tumor, and then jump back to, scalp non-healing scalp wound. So it's very versatile, and I really enjoy each and every case. I remember all of them, and there is no one case that is more memorable than the other. They're all very unique people.
Yeah, someone is asking if you have any current research in the works that are upcoming.
Yeah, we having a large research portfolio with over 100 projects that is currently run by my research fellow, Dr. Marcio Ferreira, which I think everybody's going to meet on Monday. So I encourage you to reach out to him and see if there is anything of your interest.
Yeah. Another person asked, in what ways do you collaborate with other specialties? And maybe if you can kind of talk about the specialties that you probably collaborate with the most.
Yeah, so I collaborate with all my partners. Every partner has a different skill set, and then other specialties are ENT, facial, plastic surgeon, oculoplastics. Everybody brings in a different skill set to the table. So if there is a case that I need to, let's say, remove, a sphenoid wing tumor through eyelid incision, I would ask my oculoplastic colleague to come in and do the approach, and basically open the corridor into the lateral sphenoid wing. If I need a large free flap reconstruction, I would like my my head and neck reconstructor surgeon, and we're all working in harmony, and we have amazing team that we collaborate on many of those cases together. This is a unique, I think, approach at Lenox Hill, as this is sort of a smaller hospital, so we really it's very easy for us to ask our team member to jump in and work together.
Yeah, for sure. Definitely teamwork is very important. Another person asked, what are the biggest needs you feel are needed in this field?
It's a good question. I think that this is because this is such a new and unique niche. We are, and this is why we're doing what we're doing right now, is teaching and educating as many people as possible. This is there and it's available. And the main need or challenge is to basically educate patients, physicians, population, researchers, doctors that there is this new field that is available. And it's really starting from, scratch, ground up, to elevate the knowledge and elevate the data out there to show that we can do things better and different and unique. And this is, I would say, um, the main need and challenge that we're facing every day. And this is why I'm, working a lot to give presentations just to people like you that are interested in neurosurgery and spend their summer with the brain turn programs, to know that there is another uh, option and there is a new field that can deliver better outcomes.
Yeah, for sure. So another person asked, what part of your training challenged you the most and how did you overcome it?
Training in general, or training in the field, or
Probably training in general.
Mhm. Listen, neurosurgical training is freaking hard. It's 7 years of very hard work. And that means that you have to be on top of your game every single day, sleep deprived, nutritional deprived, and and running this marathon, you need a lot of perseverance. So the challenges are, extreme, working on those stressful situations. But when you think about your higher purpose and why you're doing this, you just push through. And as long as you focus on the process and not the outcome, it allows you to persevere. And then you see that the small incremental changes, the 0.001 change at a day that you can barely even notice. But then after a while, you look back and you say, well, like I learned a lot and I got so far. I'm going to continue to push through. There is no easy way or an easy answer, but being a neurosurgery resident and multiple fellowships, med school, it's it's tough. You have to be strong.
Yeah, so another question. You had kind of talked about what made you go into wanting to help pioneer neuroplastics. Somebody had a question if there was a specific moment that caused you to be passionate about this, or if it was just something of interest, and something that you saw there was a need for.
Yeah, when I basically saw that there is a field that dedicated, I went to do my research at Johns Hopkins in Baltimore, and this is where I had a light bulb moment where I said, well, this is far beyond what I could have thinking about and could have thought about and imagined, and this is where it clicked. This is what I want to do, and that's why I came back after my chief year to do the clinical fellowship, and definitely the research part of my understanding and expanding the knowledge. What drove me to do this further.
Yeah. Somebody is asking, can you talk more about the skull implants that have the radiation beads? How does that work?
Um, well, we essentially implant local radiation seeds, and we house them in skull implants so they fit in the right spot. And those radiation seeds are cesium-131 that are implanted within the resection cavity and housed by the implant. We're going to publish a paper about that, and you should follow.
Yeah, talking about implants, somebody asked, how does the implant and skull bridge together?
Little plates and screws, standard titanium mini plates.
Let's see what else is there. Um, there is a question about if you could clarify what FNPS means at the end.
Fellow in neuroplastic surgery.
There we go. And then also, we have I think kind of one last question, unless the brain turns flood the chat. Oh, look, we got another one. Okay, so one of them is, what's your advice for aspiring neurosurgeons? And I know you kind of touched on this a little bit, but
Yeah, I would say understand that you have a higher purpose bigger than yourself. It's not about you. It's not about you or your ego becoming somebody. It's how you elevate your being to help others. And as long as it's not about you, it becomes much easier. Um, this is, a very short answer of how to do it.
yeah, it sums it up though. I think it's a very
Okay.
important short answer.
I also gonna leave my Instagram here on the chat if you want to share that so people can follow. I often publish cases, showcase how we do things, and share information about the field.
Yeah, perfect. Another person asked, are there any new fellowship programs for this field, or is Hopkins the only one at the moment?
Hopkins is the only one.
Somebody asked, what's the biggest lesson you've learned from a patient?
That becomes very philosophical. Again, every patient gives us a different lesson. Every patient is a human being, and there is something to learn from anybody you encounter in life, whether it's your patient, whether it's the person that you randomly met on the street, your teachers, or your friends. Everybody, has a lesson for you.